So can I invite the next speaker, Dr. Sujeet Kumar Mishra, who would be again taking up a very important topic, that is cataract surgery in post-Lasik and RK eyes. So a lot of young patients are nowadays going for the refractive surgeries, and they are going to have cataracts in some days of their life, and many of already have them because the history of Lasik is around 20 to 25 years, and RK is even older than that. So a lot of patients, they do come with the cataract, and it's very challenging situation, not only the intraoperative but preoperative IOL power calculation, which is most important. So Dr. Sujeet will highlight all these things. Just to introduce him, he is a fellow from Arvinda Eye Hospital. He was consultant in Lotus Eye Hospital. Nowadays, he is the secretary of the chairman scientific committee of the Patna Ophthalmological Society, and is the editor of Bihar Journal of Ophthalmology, and very meticulous surgeon.
Thank you, Dr. Subhash sir, for giving me this opportunity. So I will be talking on phaco in post Lasik and RK eyes. I have no financial interest. We all understand that we have a huge pool of patients who have undergone refractive surgery, and now they are and will be coming to us for cataract surgery. What we have to understand is that this bunch of patients are a very sensitive pool of patients who opted for a method of glass-free vision, and we are offering them a treatment that may make necessary for them to wear glasses. So this has to be kept in mind while counseling. The challenges are multifold, and they can be grouped into preoperative, intraoperative, and postoperative. Preoperatively, biometry is the major challenge. Apart from that, the challenges we face in myopic eyes routinely are the major challenges. As I told, dependence for glass, for near vision at least, will be a major challenge. Apart from that, incidence of RRD after Lasik is a little bit higher, and as in any myopic eyes, incidence of pseudophakic RD in high axial length myopia is also higher compared to the normal eyes. Then it is because glaucoma is a risk factor, myopia is a risk factor for glaucoma, so we always should have a baseline intraocular pressure measurement because of myopia per se, as well as the steroid response in these cases. Then status of granules should be looked for. Any dry eye should be evaluated properly. When it comes to placing the IOL, even if it is zero power or what, it is important to implant the lens because it maintains the barrier of anterior and posterior segment and prevents what we call endophthalmodonesis. Minus power may not be available readily in your stock, so it is important to plan your surgery looking after the availability of the lens. Then IOLs with negative spheric aberration like Technis or Acrisoft IQ or whatever brand it is will take care of the spherical aberration that is introduced because of the procedure. And multifocal IOL, the concern related with it is because it's a big eye, so centration may be an issue, so that part should be kept in mind. For biometry, we have three aspects: axial length keratometry and IOL formula and ELP related. Axial length as such, nothing great. The care we take in any long axial length eyes is applicable here. Keratometry and IOL formula related are the two things. We understand that keratometry is based on assumption, and once we ablate the surface, that relation of anterior posterior cornea is grossly violated. That is why an error creeps into the system. So it is not that we cannot measure, but what we measure is not true. Then, because we have ablated the surface, so the machine will read, it will expect a different ELP. So that has to be kept in mind. So to circumvent this condition, the concept of double K Aramberi method is there, which calculates on pre-op value of K that is used to estimate the ELP. For post-RK cases, we have not changed anterior-posterior relationship, but we have introduced irregularity into the surface. The measurement area that is different now in different zones. So that has to be taken care of by proper topography method, that an average of different 1 mm, 2 mm, 3 mm zones can be taken to have an average value. Another aspect is to take care of the post-operative decay. So empirical suggestion is if you have 4 to 6 cuts, you add 1.5. If you have 8 cuts, you add 2. And more than 8, 2.5. This is to take care of the post-op decay that is hyperopic shift after surgery. Then peri and intraoperative challenges, retrobulbar and peribulbar anesthesia, it carries a risk of globe perforation. And topical anesthesia is safer, but patient may experience discomfort due to iris movement during surgery. Recently, I had to postpone a case. That was a case of oculocardiac reflex. Sometimes that stretch gives very bad feel. And you have a multi-param monitor in your OT, then you will realize. And means that case gave me a lesson. And just before that, couple of weeks back, I was talking to a senior. He cited an example, and this is within a month. And when I was operating, and patient has all those problems, then I realized, oh. So I just gave oxygen. I stopped the surgery. And I did it under GA next day. So in these eyes, you know, although it is rare, but take it from me, it is very important. The day you come across, then you will realize. Then because these myopic eyes are different level of PCs at different levels, so you have to adjust in your phaco movements during surgery. And then you have lens iris diaphragm retropulsion syndrome. Which can be taken care of by lifting the iris by Sinski hook so that the fluid passes beneath the iris and brings the AC into normal contour. This is a case you can see. It's difficult to count the number of cuts in these cases. So what is the risk in these cases? These cuts may open up during surgery. So approach is to make a sclerocorneal incision in such cases, and then complete the surgery in routine fashion. At any point of time, if the wound gapes up, you have to suture it. Otherwise, you may end up in problem. This case went beautifully, and all the videos I am showing you is by Dr. Subhash sir only. So post-op patient is doing fine. This is a case where there is a quite space between 2 cuts, so clear corneal incision was put in this case. And everything went in a routine fashion. Surgery was completed in a routine manner. Everything was fine. But there was a refractive surprise in this case, as I told you, because that central area, that ectasia, you know, it's difficult to take the measurement sometimes. So there was a huge surprise, and patient was very happy. So the lens has to be removed, and another lens of proper power was placed. Post-operatively, it's a routine as we give in other eyes, keeping in mind myopic eye, any dry eye related issues, and then steroid response you have to keep in mind. And because these are myopic eyes, so retina should be evaluated properly in post-operative period. Any residual refractive error should be addressed properly. Later on, if you have to do any YAC capsulotomy for the posterior capsular opacity, try to use minimal energy for that. And once you operate the one eye, then there should be proper counseling for other eye surgery so that the duration of anisometropia is reduced. Thank you very much.
Thank you, Dr. Sujeet. I would just like to know for those who actually, those who don't have advanced machine biometer, in those situations, how do you advise them to do the biometry, and how do you proceed with these patients so that you don't end up with the refractive surprise?
Yeah, basically we have online calculators, ASCRS online calculators are there where you can feed those datas, and apart from that, the counseling is the main part. You have to sensitize the patient because it's about measuring which is unmeasurable. When there is error in the system of measurement, or one practical suggestion I will give to them, refer the patient to a place where they have good equipments, because number one, these patients are not common. If they have landed up to you, you are not sure about the biometry, don't hesitate in taking help of a center which is having that equipment, state-of-the-art equipment. Patients, they won't run away. They will come back to you, and once you do a good surgery, they will be very happy. They will be thanking you.
So surgery is not difficult in those patients who have undergone laser vision procedure, but IOL power calculation is the most challenging thing, and nowadays with the advancement in the biometry, these problems are a lot solved. But not all of us have access to these higher end gadgets. So for those, it's always better. One thing is that the proper counseling is very important, because I have expanded or done lens exchanges in at least 10 patients, all having undergone laser procedure. So those patients have to be pre-operative, properly counseled. Then, as he's saying, there is no ego problem in taking help of somebody who has higher end machines to do the proper IOL power calculation. So now we have the IOL Master 700 and many other machines who can actually calculate the posterior corneal curvature also. So in that way we can just be on spot on, and nowadays you can even plan for trifocal lenses in these patients, and that gives also very good results. And regarding that RK, in one video you have shown that you can do the lens exchange. It's always very difficult to do the IOL power calculation in IOL exchange in those patients. That video was very old. My video was very much old, and at that time I did not find any other better option, because the piggyback lens was very costly. So nowadays we have Indian piggyback lens that is very cheaper. So instead of removing those lenses, because IOL power calculation is again going to be a problem, and you may again land up with a surprise. So I think that it's better to do piggyback lenses in those cases. Any comment from?
When it came about piggyback lenses, what I remember, correct me if I am wrong, that the piggyback lens is in a way that if the previously lens implanted is hydrophobic, then it will be hydrophilic. Am I right? Yeah. Okay.
So your experience on Ellen, because you are a cornea surgeon, and yeah.
One thing what we can do is we can just ask for a pentacam or something from
Yeah,
the
yeah.
institute. Take that pentacam with the EKR readings. Go for the 4.4 millimeter reading.
Yeah.
Put that reading into the online, then it will be as good as calculation. That's point.
Yeah, I mean referring the patient, I mean that getting the data. Means, and once you are referring, you are getting pentacam, then whatever machines are there, they will get it done. But yes, that is what I said, the online calculators are there, they are very helpful. So definitely.
Micropic, another, even with that formula, we have to undercorrect those patients for RK.
RK.
Early post-operative phases, sir. Early post-operative RK patients, early post-operative phases, we often get hyperopic shift.
Yeah.
After 1 month.
Yes, sir. The corneal edema.
Even then with the readings, we have to slightly
We have to
So
overcome,
that is
yeah.
what I had shown the slide. And that.
So thank you.
Yeah.
Yeah.
One question, the ASCRS calculator that you are using, for the post-RK patients you've given, so how to undercorrect the patient depending upon the incision. In LASIK patients or other refractive surgeries, how much you are undercorrecting?
No, there is no shift. You have to understand this post-op decay. This post-op decay is there in RK patients only, not in post-LASIK cases.
Post-LASIK also, according to the ASCRS calculator, also we are keeping a little bit of undercorrection in those patients also, sir. So how do you use the calculator in that case?
So have you seen the suggestions they give in ASA? They don't give one suggestion. 3 give. So if you look at the readings, it's very difficult even after that ASCRS, you cannot be sure enough to use any one of them. So that is why what I told in the beginning, you are handling a sensitive pool. Unless R&D equip us with pakka answer, you have to live in state of dilemma. That,
Normally are undercorrecting by 1 diopter
I'm afraid if that statement is means generalized, can be generalized or not.
Well after the post-operative period, but we haven't studied it so far. Normally that's the protocol in our case.
So rule of one, I'm not sure how much it will be applicable.